Today we're going to be discussing about Parkinson's disease associated psychosis. So let's recall what happens when you have Parkinson's disease. Parkinson's disease is a disorder where your dopamine receptors, dopamine is reduced in the brain. So your aim basically is to increase the dopamine in the brain, and that's the whole idea. So when you increase dopamine in the brain, the other side effect of increased dopamine in the brain is psychosis. And this is what we're talking about here. Parkinson's disease associated psychosis. Now, when you talk about Parkinson's disease associated psychosis, what are the prominent symptoms that you see in such patients? The two most important prominent symptoms that you see is one being visual hallucination. So very often, or more often than not, you see patients having visual hallucination, paranoid delusion. So patients come to you, walk in the clinic, talking to someone in the family who's not even present there, and that is paranoid delusion and hallucinations as well. Now, it's a little tricky situation here because you want to treat the disease Parkinson's. At the same time, you may end up giving the patient psychosis, even though the patient did not have psychosis to begin with. So we are trying to understand what exactly causes, what are the medications that increase the risk of psychosis. All the medications, first of all, increase the risk. Any medication that is aimed at increasing the dopamine level, which is in fact the treatment for Parkinson's, is going to cause increased psychosis. But drugs which are dopamine agonists, which directly are dopamine agonists, like ropinirole and pramipexole, these are the drugs which particularly are associated with a greater risk of psychosis than the other classes like dopamine precursors or the gold standard anti-Parkinson medication like carbidopa-levodopa complex. Now, after having understood this, so the whole idea is you have the patient had Parkinson's, you give drugs to increase dopamine, because the whole idea in Parkinson's is reduce dopamine, but at the same time increased dopamine in the brain is associated with psychosis, so you gave the patient psychosis. The patient presented with symptoms like visual hallucination and paranoid delusions, which are most commonly encountered. Now, what is the class of drugs which is most associated with this complication? It's dopamine agonists like ropinirole and pramipexole. Moving forward, how do you treat this patient? That's the biggest question, because the patient will come to you, and how do you treat the patient? That will be the whole gist of this discussion. Now, the understanding is when you give the patient drugs, the first thing you have to try is reducing the dose. So reduce the dose of anti-Parkinson medication. So whatever medications you're giving, you try to reduce the dose. Now again, this is not really a very good way of doing stuff, because the moment you reduce the dose, the patient will throw up motor symptoms. So you don't want so patient, eventually, the patient will be in trouble. You may reduce the psychosis which you gave to the patient, but again, the patient will, the initial problem with which the patient came back might actually flare up again. So we're back to square one. Parkinson's is back. So if this does not work, the second thing we can do is we can substitute the medication. So as I told you, dopamine agonists have the highest risk. So you may actually substitute with other classes like maybe dopamine precursors, or maybe raise the dose of carbidopa-levodopa. If these things don't work, the medication which is primarily aimed at the psychosis, the psychotic part in Parkinson's disease complication, is going to be low potency antipsychotics. So low potency antipsychotics is the drug of choice. So low potency antipsychotics is what you have to give the patient. And what are the drugs that are low potency? You have quetiapine, you have clozapine, and you have pimavanserin. So let me just mention them here. So quetiapine, clozapine, and pimavanserin. These are the three drugs that you can give the patient, as they are low potency with minimal dopamine receptor antagonism. The whole idea is that you want to give drugs which do not act against the dopamine receptors. So because they are low potency and they have least action against dopamine receptors, these are the preferred drug of choice. Sometimes you may be tricked into thinking the answer is going to be haloperidol, because the patient they'll give you vignettes like the patient walks into your clinic and is completely psychotic. He's talking to himself. He's having visual hallucinations. And in such cases, you tend to think as the drug of choice to be haloperidol because this is what is practiced in most of the emergency departments. But that would be absolutely a blunder because you will end up giving the patient extrapyramidal symptoms and will probably worsen the Parkinson's motor symptoms because you are going to block the dopamine receptors because they are dopamine blockers. They're D2 receptor blockers, and that's why they're supposed to be avoided. So that's the whole idea here. Let me summarize it for you. So the treatment consists of first reducing the dose and see if it works in both the ways. The motor symptoms are at bay. You keep them at bay, and at the same time you prevent any sort of trouble in context of psychosis. If that doesn't work, you try to substitute the medication. What substitution? You go from dopamine agonists. So remember, dopamine agonists have the highest risk of Parkinson's psychosis, so you may want to substitute with something else. And if nothing works, eventually you will come down to treatment of it, which is low potency antipsychotics, and that wraps up your Parkinson's associated psychosis. Thank you.